Today we'll be talking about revision surgeries, and it's a very interesting topic. Hopefully it's going to be proven very beneficial. This is something that we see a lot in practice, and there might be different type of treatments depending on someone who had a prior surgery. So the first thing that we want to dive in will be talking about people that they have already a spine fusion. So Dr. Brusovani, can you able to elaborate what are the possible scenarios, what can happen when someone has a spine surgery or fusion hardware, where the problem might be coming up from if some of those patients persist with pain or the pain come after surgery at some point?
So the most common thing I see in a patient who has already had a spinal operation, specifically a fusion surgery, is what's called a non-union or a pseudoarthrosis. So this is an operation where a surgeon tries to make the vertebra or the spinal bones knit together in a better position. You do take away motion between those bones, but the idea is that motion between these two particular vertebrae is painful. Now, screws are placed in the back, and that can be done in both an open and a minimally invasive fashion. And then various devices are utilized to replace the disc. The most common that I see as part of a failed operation is a small piece of plastic that's implanted as part of an operation known as TLIF or TLIF. In this operation, a surgeon tries to dig around the spine to get into the disc, and the device itself is minuscule, so it doesn't truly accomplish the goal of replacing the disc. Many of these, and has been shown in literature, up to 25% go on to a non-union, and patients really suffer extensively with continued back pain after surgery, as well as possibly pain going down their legs.
How about the level above or level below the surgery? Because that's common, right? If you have a fusion, there's no movement. So what happens to the level above or level below? Because we want to still preserve the mobility. What happens to those levels?
Absolutely. Thank you for asking. So that's the second most common cause of a failed back surgery operation. So the problem is what's called sagittal balance. We have learned that if you don't restore patients' normal height by increasing space between the bones, essentially by placing a disc replacer that approximates its original height, we will doom the patient to a 36% failure rate. You know, that urban legend that spine surgery never ends once you start, it is real for as many as a third of the patients. And the rationale is that if we leave the patient in a forward flexed state, if we don't restore their normal spinal contour, it's like a willow tree that you will support halfway through the bend. With time, that willow tree will just bend right over your support. So we see reliably within a year or two or five, as long as 5 after surgery, patients present with a problem right above the fusion. And here technology really shines. Once we confirm that the problem is indeed coming from an adjacent level via specific transforaminal injections that you do so well, we will sneak in again with a tubular retractor right above the fusion. This allows a surgeon to avoid injuring muscles, avoid injuring nerves, and negotiate into the center of the human body, which is where the human spine is, in the safest way possible. Through this approach, with really good lighting and with a microscope, you could remove the problematic disc, either replace it with a disc replacement or with another fusion device, and restore patients' normal spinal anatomy. Essentially, when these operations are performed correctly for patients who have proven that that's indeed where their pain is coming from, the patient wakes up and their pain is gone. It's a really rewarding operation as well. Dr. Mena, I find that not every failed back surgery requires more surgery. Patients come from all over the world to see me for these, and frequently I see them getting better with proper injections. So if I may ask you, what are some of the techniques that you use to isolate the level, to figure out exactly where the pain is coming from?
Yeah, I do agree with you. Most of this kind of we have been talking about uh, revision surgeries and all that, but we know that most of the patients, they might not benefit from revision surgery. Most of them, they might respond to conservative care, and that will be entailing with an exercise program / physical therapy, and or the use of spinal injections. When we talk about spinal injections, we normally need some image guided in order to place the injection in the right location. When we're talking about adjacent segment disorders, typically, which is the one that typically once you have a pseudoarthrosis or failure of fusion, normally those patients they might require a revision surgery. But when we're talking about adjacent levels, a lot of the patients, they surprisingly, they might not. So most of the time, 40% of the time tends to be an SI joint or secondary leg joint disorder. That's a very high number on patients. So we use X-ray guidance. Of course, we use our physical examination skills and history taking skills in order to put everything in together, and we do the injection X-ray guided. Another possibility might be the disc, a herniated disc, or the disc as the discogenic pain as the adjacent segment, and normally they might benefit from an epidural steroid injection. Normally, the way to do it will be transforaminal guided, because we place the injection around or very close to where the source of pain is, or the pain generator. And finally, the other possible contributor might be facet-mediated pain, which in the reality, we treat those with radiofrequency neurotomies. Of course, we want to make sure that we exclude the hip if we're talking about the lower back, or the shoulder if we're talking about the neck, because they can be very common pain generators. And again, we use X-ray guidance, and once we confirm that with a history and physical examination. But I agree, most of the patient with an adjacent segment disorder, they might benefit from conservative care and might not warrant any interventions.
Dr. Mena, what is the role of the spinal cord stimulator? Sometimes patients fly in to see me, and we determine that operation is just too much risk. What do you see happening with patients who are properly selected for specifically spinal cord stimulation?
Spinal cord stimulation, I will say, is one of the last resort procedures that are being done. Normally, the indication will be, for the most part, tend to be pain in the sciatic type distribution. Those are what we call the home run patients. And normally you do a trial first, like a test run. So just to ensure whether the patient gets the relief for 5-7 days, duration of the trial. And if it works, actually that can be implanted. But normally I agree with you. Typically it's like a last resort procedure, and nothing else has being found, and the patient does still persist with pain, and they are pretty much a candidate for this procedure. Again, I always will try to fix problems that if there's a solution, surgical solution or interventional solution prior into committing a patient for a neurostimulator or a spinal cord stimulator.
Do you feel that this procedure is well indicated for patients who have chronic pain, who are paralyzed and beyond fixing?
It depends. Typically, unless the patient does have any kind of a nerve pain in a specific distribution, very limited. Normally, those are what we call home runs. Those patients, they might do well. In more an overall type of pain, normally they're not candidates for this device. So, as wrapping up, basically, we know that most of the patients that they already had undergone a surgery, most of those patients might not require an adjacent segment surgery or revision surgery. Most of those patients might require or might benefit from conservative care. Of course, we have people like you that if nothing has failed, everything has failed. We're glad that we have resources that these patients might benefit from. And again, I would like to thank you. And of course, this has been very useful, and I hope that this was useful as well for the audience. Thank you so much for having me here and joining me again.
Thank you, Dr. Mena.